Well, folks, if you're logging on, thank you for joining us this evening for an important webinar, Value at the End of Life. If you are just logging on, please feel free to jump on the chat area and you'll see the button at the bottom of your screen and just tell us where you're logging on from. I see people logging on from Northeast Philadelphia to Downingtown to Williamsport to Ephrata, even North Carolina. Wow. It's probably a little warmer down there than up here in Pennsylvania. We have people logging from Mifflinburg. This is just great to see so many people logging in from Lancaster. Let's see, Downingtown. I said that already. So it's great. Yeah, if you're joining us now, just go ahead and tell us in the chat area down below where you are logging in from. Wilkes-Barre, that's great. Chester County, even Reading and Mount Joy. So Hershey area, that's where the good stuff comes from. I've had way too much of the good stuff, Hershey chocolate. So, but love Hershey. Well, my name is Kurt Weaver, and I am the director of the Church Ambassador Network with Pennsylvania Family Institute. And just so happy that all of you have joined here this evening. I'm just going to quickly read a verse from the Bible that's somewhat fitting for our topic tonight, and then I'm going to pray, and then we'll get things started here this evening. By the way, you're going to love the panelists that we have tonight. So make sure you stay to the end. Lord willing, we're going to be ending this at 8 o'clock, and we will have a question and answer time at the end. And by the way, you will see that button on the bottom of your screen as well. You'll see a Q&A area, and if you push that button, you can ask questions there, and we'll be able to answer those later at the end of the webinar. But I'm going to start here. Philippians 3, the Apostle Paul is writing. I'm not going to read all this section, but he writes this, that I may know him, Christ, and the power of his resurrection, and may share in his sufferings, becoming like him in his death, that by any means possible I may attain the resurrection from the dead. You know, some might think that this topic this evening is somewhat morbid, or maybe even difficult to talk about or even join a webinar on, but you all have, and I think it is important as we talk about the importance of the value at the end of life, and as we talk about assisted suicide. But here what's fascinating is Paul is talking about how enduring to the end, even in the sufferings of Jesus Christ, suffering in death to attain the resurrection of the dead, from the dead. And that is really our hope as Christians, right? We trust the Lord with our lives. We even trust the Lord in the very end of our lives, trusting him with our last breath and knowing that he is the one that holds each and every days, all of our days in his hands, and he has numbered our days before the foundation of the world. It's a beautiful thing, and I think it's important for us as Christians to even think about, what does it mean to end well? What does it mean to suffer well at the end of life? And you'll be hearing more as we go on here with our panelists. But let me just pray to start us here this evening. Father, I just pray as we enter into this webinar on a topic that can be hard to talk about, the end of life, death. Father, help us, open our hearts and our minds to hear from you and to hear from these panelists, Lord, what it means to care about life and to end well. Father, be with us this evening and be with all the people that have joined us from all across the state. Bless them in every way. In Jesus' name, amen. Well, tonight we are joined by a great panel. We have Tom Shaheen as one of our panelists. He's our VP for Policy at Pennsylvania Family Council. And we also have three other panelists who are professionals in this area. And we're grateful to have them on. We have Dr. Joseph Marine, a cardiologist. We have Dr. Kristen Holt, a clinical pharmacist, and they'll be able to tell you later on about their jobs. And also we have Dr. David Closson. He is joining us here this evening as well, and he's the director of the Center for Biblical Worldview at Family Research Council in DC. So, thank you very much to our guests for joining us here this evening. Well, I'm going to throw it to our Vice President of Policy at PA Family Institute, Tom Shaheen. Take it away, Tom.
Well, thank you, Kurt, and hello, everyone. Let's start with a little background. For many years now, physician-assisted suicide legislation has been introduced in the Pennsylvania legislature. And each time, by God's grace, it has not gained any traction beyond those who sponsored and co-sponsored those bills. But what we're watching and concerned about and want to be prepared for is that right now across the country, there are 12 states that currently have legalized assisted suicide. And yeah, there's a graphic, just you can see it just graphically. The states that have legalized it have had dire consequences that we want to point out to you and also help you to understand more about the process that's actually done versus the euphemisms that are used like compassion or aid and dying. So currently in the Pennsylvania legislature, and we'll have more detail on our website, pafamily.org/assisted suicide. But currently there's a Senate bill 570 and a House bill 1109. So different language, same purpose. And then the proponents across the country that include some legislators, some advocates within medicine, say that they are helping physicians to die without suffering and that they're dying with, quote, dignity. And so we'll explore that tonight. What these bills do is actually something very, very different. So Dr. Marine, as a cardiologist, I think you've acknowledged this has some scary implications, some of which have played out in other states. What are your concerns? What are your main concerns with this type of legislation and legalizing it in a state?
Well, thank you, Tom, and thank you for having me on this program. I have many concerns, and first to take a step back to talk about what we're talking about here. These bills create a legal process that allows a licensed physician to prescribe a lethal overdose of a set of drugs which have never been approved for this purpose. It's generally a concoction of different drugs that we'll talk about. So you're basically taking a person who has a serious illness, deemed to be at end of life or near the end of life, in your office and handing them a prescription that a pharmacist then fills, and the patient then consumes those drugs to be used as a poison to take their own life. And it's important to understand that this is not hospice care, palliative care, many legal and ethical ways that we have to take care of patients at the end of life. This is something quite distinct from that. So I have many concerns about this. First of all, is that it's unethical for physicians. Going back to the oath of Hippocrates 2,500 years ago, neither will I administer a deadly drug to anybody when asked to do so, nor will I suggest a course. And coming fast forward to the AMA, which has asserted that physician-assisted suicide is fundamentally incompatible with the physician's role as healer, would be difficult or impossible to control, and would pose serious societal risk. And the AMA recently just affirmed that policy. The American College of Physicians, the second largest physicians organization in the country, opposes legalization, as does the National Hospice and Palliative Care Organization, the World Medical Association, and many others, because it's really a core ethical principle that protects the public and protects the medical profession. Secondly, it's not medical care. There's no basis for this practice in medical science or medical tradition. There's no guidelines, there's no standard of care, there's no training for this. Nobody would confuse giving patients a cyanide tablet or carbon monoxide as medical care. And so this is not medical care either. Third point is that it's dangerous. The safeguards in these laws are really an illusion. There's no requirement for psychiatric evaluation, minimal informed consent, no witnesses, no routine audits. Physicians are granted immunity. There really is no safeguards around these practices. It's based on false prognosis. The idea that a physician can know when an individual patient has 6 months left to live is really a myth. It's discriminatory because it really affects people who have disabilities, people who have advanced illnesses, and it tells them that your life is less valuable and less worthy of the protection of the law. It's unnecessary because we have excellent palliative and hospice care options, and this is really what legislators should be promoting and making more available to their citizens. It will lead inevitably to other forms of euthanasia, as it has in the Netherlands and in Canada. Most physicians will not practice this. Only a small number of physicians in the states where it's legal have anything to do with this. And finally, it will affect everybody. We say that medicine is a public trust. This will affect the ethos of medicine, not just for people who choose it, but for everybody else. And it will result in a medical profession and healthcare system that is less caring and less compassionate.
Thank you, Dr. Marine. Dr. Holt, as a pharmacologist, why are you concerned?
Well, thank you for having me, Tom, Kurt. Appreciate the opportunity to be with you today. So I'm a pharmacist, and I am also a member of the Maryland Family Institute, and I want to just take a moment briefly and thank the Pennsylvania Family Institute for your inspiration. A few years back, we didn't have a Maryland Family Institute. We now have one for about 2 years. And you were one of the inspirations that we were praying into having something like this in Maryland. So thank you for being steadfast in your state. You also sent Jeff Trimbath to us, returning back home to Maryland. And we're so grateful that you sent one of your best. I also want to thank you because you are inspiring the next generation. And my nephew has been very involved in your organization, and it's taught him how to advocate for family values. So thank you. Thank you so much. And thank you for having us today. On this subject, I briefly want to just have us think back to that visual that we saw of the map of the US and states that have rolled out physician-assisted suicide. It's now law in 12 states. That's 23% of the US population that now has access to medical aid in dying, according to their academy. So the blue states, that's where it's passed. The red states that you saw, that's states that have bills that they're considering this. On this topic of end of life, I just want to start out to say I have empathy for anyone on this call who is in a stage where they are dealing with terminal illness themselves or with a loved one that is facing the end of life. There are a lot of feelings that can go with this: pain, fear, isolation, and even a sense of powerlessness. So I have deep respect for what you're walking through, and I appreciate you taking the time to be a part of this call. So from my experience, I want to speak as both a provider and as a family member of someone who had several loved ones with terminal illness. And walking through that process, I have developed a deep respect for pain management, for palliative care, hospice, chaplains, home care, other professionals that are serving end-of-life patients. It's all needed. I've seen the value of this skilled care and access to these resources make a difference. I'm an advocate for expanding high-quality training across physicians, pharmacists, nurses, and other healthcare professionals. We already have great solutions and information on how to do this well. I would like to see our legislatures focusing on this type of support for more people. I'd love to be invited into that discussion. Regrettably, what I see our legislatures doing is proposing a very different and alarming solution. I am deeply concerned. That's why I got involved. I want to tell this audience about the drugs used as aids in dying and how they're used to overdose to cause death. I would also, secondly, like to just express my concern on the impact to the human spirit and society. So I agree with my colleague, Dr. Moraine, and I agree with the AMA stance against physician-assisted suicide. As a pharmacist, we too are dedicated to the Hippocratic Oath to first do no harm. I want to make it very clear, the End of Life Options Act in Pennsylvania, the Compassionate Aid in Dying bill, those terms are misleading. These easily meet the AMA definition of physician-assisted suicide. So this is not palliative care. It is not making people comfortable at the end of life. It is giving Pennsylvanians access to overdose on drugs to kill themselves potentially months before natural death.
What can you tell us? Tell us more about the drugs that are used.
Sure. So my goal for nearly 20 years as a pharmacist is to be dedicated to ensure safe and effective medication use. So when I saw the recommended prescription from the Academy for Aid in Dying, I felt sick to my stomach. Opioids, benzos, and other medications are prescribed up to 500 times the clinical dosage. There's no doubt the overdose would stop the lungs, the brain, and the heart. So I'd like to speak to any clinicians on this call. I encourage you to check out the Academy of Aid in Dying Medicine and their recommended protocols and prescriptions in the chat for the purpose of reviewing prescriptions like this. My testimony that I provided to the Pennsylvania Family Institute is going to be on their website with a comparison of typical dosages. What you'll find here in this prescription is a recommendation for death day: DDMA-PH, digoxin, diazepam, morphine, amitriptyline, and phenobarb, and toxic overdoses. So let me just break it down for you, particularly for clinicians on the call. The morphine dose here is 15 grams, not milligrams, grams by mouth. The typical initial dose clinically is 15 milligrams with a max of 30 milligrams every 4 hours. So what that means is to reach 15 grams here, that's equivalent to 500 to 1,000 pills. Several other drugs are included here to enhance the sedative effects. The clinicians with Academy of Aid in Dying Medicine reports that it's primarily working by slowing breathing, leading to a coma, and ultimately causing cardiac death. A cardiotoxic dose of digoxin, 100 milligrams, is used. This is 200 times a clinical loading dose in the event the recipient is younger or athletic with a stronger heart. With an eye to safety, let's be clear, the goal is the opposite of safety. The goal here is death. So as the AMA stated, that's incompatible with our role as healer.
Thank you. I think you stated, it's incompatible and the opposite of what we want as far as providing patient safety. Can you address the idea that there may be safeguards within some of these bills? Because I know that's what some of the proponents use in their advocacy.
Sure. I'd be happy to lead off, and I know Dr. Moraine has some additional comments here. What I'll say is I did briefly look at the Pennsylvania laws, or bills, I'm sorry, the Pennsylvania bill regarding this. And the proposed law, it does look similar to Maryland in some way. There are some differences. Right off the bat, one of the differences is that in Maryland, it specifies that the terminal illness would need to be within 6 months of death. And in Pennsylvania, there is no such stipulation. So as soon as you get a diagnosis of a terminal illness, you'd be qualified for this. But in Maryland, I'll speak to that because I'm most familiar there, just to give you a heads up in case any of this arises in Pennsylvania. In Maryland, it's said to be administered without a healthcare professional supervision. The bill requires MAID to be recorded as natural death on the death certificate, which means it's difficult to track when there are these instances. So not only is it difficult just to track it, but it's difficult to track any safety issues. So what you have here is a situation where there's potentially no witnesses, encouraged, but not required. Not required to have a healthcare professional. It's not required to document that it happened. So do we really know what's going on? There's issues with storage in the home and access to minors. A mental health assessment is not required, only at the discretion of the ordering physician. But lastly, what about prognostic timing of terminal illness? We all know it's variable. We all know someone who's had a different experience than what was the prognosis and the timeline. So my own father was diagnosed in my teens with pancreatic cancer. It is a very aggressive cancer. And it turned out he lived 3 more years because it was duodenal cancer. So I would like to stress that point.
Dr. Marine, how would you address that?
Yeah, those are terrific points. And, my own father had coronary disease, very severe coronary disease as a young man in his late 30s, and he was told to retire and make out his will. And he lived for 40 more years with good medical care. So there's studies actually that show that patients who are referred to hospice, who are supposed to have a 6-month prognosis, 15% of them live for more than 6 months. And of those, about half of them live for more than a year, and a few even graduate from hospice because they never had a terminal diagnosis. Everyone's probably familiar with President Jimmy Carter, who passed away a few years ago. He'd been referred to hospice 2 years before he passed away with metastatic melanoma. So it just underscores that. People have lived up to 4 days after taking the pills. So we don't know that these pills will always work for every person. Another thing that's very troubling about the way the laws are structured is they do not specify what drugs are to be used. So a doctor can literally give any concoction at all that comes into his mind, and almost any drug can be used as a poison. These formulas that have been used are really experimental, and there's no science behind them. They've never been conducted in any kind of controlled circumstance with oversight. There are examples of where experimental concoctions have been used that caused people great pain before they died. You said that there's no witnesses, which is true. In about 80% of cases in Oregon, there's no medical witnesses, so we don't know what complications occur at the time of death. And then finally, it's very troubling that it's required that the death certificate be falsified as to the cause of death. You may be muted, Tom.
All right, sorry about that. A little technical glitch prevented me. We're concerned about coercion. And do you think, well, what we've seen, and you tell me more, is that the disadvantaged, especially those who are with disabilities, those with maybe not just a terminal illness, but even those who are up there in years, that there's coercion, whether it's overt or under the radar. Can you tell us more about that, what you've seen?
Yes, that's a very troubling aspect, and I've really learned a great deal from my colleagues in the disability rights community in my time opposing these bills in Maryland. They've had a lot of stories that has made me more aware of what they face often from healthcare providers, the discrimination they face, the sort of subtle messaging that is sent that maybe their lives aren't worth continuing and it's not worth continuing on with medical care. To sometimes even frank suggestions that they should take another path. So I've really learned from them the concerns that they have. And this is why almost all disability rights organizations in the United States oppose physician-assisted suicide. They see a target sign on their back, frankly. And many have expressed the concern that what today is being framed as a choice, gradually and particularly under economic and social pressures, will become an expectation.
Okay. What have you seen, Dr. Marine or Dr. Holt, about the expansion once these bills are passed?
Sure, I can share 2 points on that. First, I'd like to speak to the suicide rates. And so, first, we know that over the last 2 decades, the suicide rate has increased substantially in both the US and in Pennsylvania. So, the End of Life Option Act makes self-harm an acceptable medical option in Pennsylvania. So, I've begun researching the concept of community resilience, and I'm intrigued by a resilience study from Stanford. The researchers found that it's not stress that kills you, but it's what you believe about stress that does. So if we remove the will to live, we remove a community commitment for someone to live, we remove purpose, meaning, and a goal for our final days. I believe it has ripple effects for others that see suicide as a more desirable option already than the distress of living. So secondly, I would like to address the idea of made in Canada. So what's going on in Canada is worth our attention. Pennsylvania legislators who are proponents of MAID want to probably draw distinctions. So I want to let you know that we need to learn from our neighbors. It's important to think about this as a trajectory, not just about one state or another state, but think about in 10 years and over decades. Since the Canadian law passed in 2016, roughly 10 years ago, MAID now accounts for 5% of Canadian deaths annually, almost 5%. It started just for terminal illness. It expanded to not requiring terminal illness to be a diagnosis to any grievous and irremediable medical condition, a serious illness, disease, or disability, an advanced irreversible decline, physical or mental suffering that cannot be alleviated under conditions acceptable to that person. There's also the intention to expand this to a diagnosis of mental illness alone. And in fact, the law was passed, but they needed to come back together and delay the enactment to March of 2027 because they realized how this would affect the landscape of Canada. So I think in pursuit of equity to alleviate suffering, you would find expansion over time if allowed in Pennsylvania.
Absolutely. And we've seen this happen also in the Netherlands and Belgium. It's expanded to children and it's expanded even to people who are given euthanasia solely for a mental illness, for depression, anorexia, PTSD. So, there's very few things where once you grant that something is a right, that it doesn't inevitably expand to others. We haven't seen a great deal of expansion yet in the United States. There are some states that have expanded to allow nurse practitioners and physician assistants to prescribe. There's some that have removed residency requirements. There's some that have removed the 15-day waiting period. So there are signs of slippage already in the United States, but I think that if a critical mass of states pass assisted suicide laws, it's inevitable that there will be a rush to expand to full euthanasia and to even fewer safeguards.
Dr. Marine, we know there are disparities in healthcare. How is that so with physician-assisted suicide and how that's applied, and even medical abandonment?
Yes, well, that's a very troubling aspect, particularly that we see in other countries where we see examples of people who don't have access to care, to help with their disability, choosing euthanasia. And there's very well documented instances of this in Canada. We've not seen as much of that in the United States, but I think it's inevitable that if assisted suicide and euthanasia expands here, those same kind of pressures will be brought to bear for people who are more vulnerable, will become more prone to being nudged towards this option.
Okay. Dr. Holt, any comments you want to make in closing, and then Dr. Marine as well to follow, and then we'll go back to Kurt and David Closson.
Sure. Well, thank you for having me, and I applaud the Pennsylvania Family Institute for fulfilling its mission to build a Pennsylvania where God is honored, life is cherished, families flourish, and religious freedom thrives. So if our purpose is to love God with all our heart, soul, mind, and strength, and to love our neighbors as ourselves, then the most loving thing that we can do is to trust and obey God and to love others as ourselves during each day He has ordained for us. There is growing empirical evidence that our beliefs, our relationships, and our spirituality can significantly positively impact our resilience and health. We talked about pain and palliative care, hospice, and that expertise available at the end of life. And I urge Pennsylvanians to promote greater access to these services that can clarify goals, purpose, and resources for this transition. Let's embrace the options we have with a positive impact to the human spirit and our community resilience. Let's continue to rally around those at the end of life. Honor them as uniquely made in the image of God and affirm purpose to each day. Thank you.
Thank you for that. Dr. Marine, anything to add?
Thank you, Tom. It's been great to be on this program and to speak to your viewers. From my standpoint, assisted suicide is simply terrible and unnecessary public policy. Handing a patient with a serious illness or disability a prescription for poison is simply not medical care, and it's not compassion. Compassion means walking with someone in their suffering, and that's being with them. We have excellent tools already: hospice care, palliative care, pain management programs. We've never had less need for any form of euthanasia in human history than we do at this time. So I hope that we will all collectively promote those better options for our patients and for our fellow man.
Well, thank you. Thank you both. I'll turn it over to Kurt, and we'll hear from David Closson.
Yeah, this has been great. So appreciate both of you and your expertise, Dr. Marine and Dr. Holt. Dr. Marine, before we jumped on here, I was mentioning some of the confusion between the removal of medical support and assisted suicide. Can you just quickly address the differences between those two?
Yes, that's a very important distinction that even some doctors and healthcare professionals are not familiar and comfortable with. It's been well established in law and medical ethics that when someone is in the dying process and they're being kept alive through medical support, such as a ventilator or some other extraordinary means, there is nothing unethical about removing that support if it is that person's wish, or their healthcare proxies' wish on their behalf. That is already well established that people can refuse any and all care if they do not wish. What we're really talking about with assisted suicide is something very different. It's a deliberate act of taking a poison to end one's own life.
I think that's an excellent clarification, and I think many people misunderstand what assisted suicide is, and certainly, removing care at the end of life. So grateful that Dr. Closson is on here. Dr. Closson, you've recently written on this topic, and I love what you're doing over at the Center for Biblical Worldview with the Family Research Council. I wanted to just start off right here. Or by the way, folks, if you do have questions, at the bottom of the screen, you'll see the Q&A button. You can go put your questions in there. And don't worry, we're going to have Dr. Marine and Dr. Holt on here at the end to answer some of those questions as well. But David Closson, starting with a biblical worldview on assisted suicide, the Bible doesn't mention assisted suicide. So, how do you give a biblical defense against physician assisted suicide?
Well, Kurt, I want to just start by again thanking you and the Pennsylvania Family Institute for hosting this webinar. This is a really important conversation. You just mentioned my title. I work at the Family Research Council here in Washington, D.C. And what we do at FRC, there's about 38 state level groups, including Pennsylvania Family Institute, that are doing this important work in state capitals. And I just think this is so important. This is one of the first webinars I've done on this topic. And again, just kudos to PA Family for making sure we're thinking about this well. To answer the question directly, Kurt, when we approach assisted suicide biblically, I think the starting point needs to be who is God and who are we? Scripture teaches that God is the author of life. Human life is not self-generated, it's not self-owned, it's not self-caused. The teaching in the Bible, again, the very first chapter of the first book, Genesis 1, says that human beings are made by God and in the image of God. This teaching gives every person, regardless of age, health, prognosis, it gives everyone intrinsic worth and dignity. That's where the Bible starts. So I think that's where we should begin as well, with this just understanding that God is the author of life. Another thing that's important that should frame the conversation from a biblical perspective is that the Bible draws a clear moral boundary around intentional taking of innocent human life. The sixth commandment that Moses received on Mount Sinai, thou shalt not murder. This establishes a moral absolute. And the thing about moral absolutes is that they are absolute. They're not overturned by even things such as suffering or consent. The fact that someone requests death does not transform killing into care. God alone has authority over life and death. And so I think this is really foundational to what it means to actually have a biblical worldview. The whole discipline of Christian ethics also emphasizes what I would call intent and agency. And we just got into this with Dr. Marine, but it's morally significant that there's a difference between allowing death to occur through the natural progression of death versus intentionally causing death through lethal medication. You know, Christians can and have always affirmed hospice care, palliative care, the refusal of extraordinary medical intervention, well, all at the same time rejecting assisted suicide, euthanasia, you know, whatever the euphemism of the day is, seeing that as morally impermissible. Again, we already talked about this, but this is so important, and I do hear this, Kurt. Christian ethics treats direct killing as categorically different from allowing death to occur when the body can no longer sustain life. And we're all going to get there. We live in a Genesis 3 world. Death is undefeated. I think the last thing I'll add on this first question is we're just kind of setting a biblical framework, is that a Christian biblical ethic, it actually provides us with a framework of suffering. The Bible never minimizes pain, but it also refuses to say that suffering makes life meaningless. We know this as believers, that God often works through suffering to deepen faith. This goes back to the scripture you started this whole webinar with, Kurt. But I guess if I had to sum it up, you know, the Christian response to suffering it can never be death. It's rather one of faithful presence, compassionate care, and really a hope that's rooted in our belief in the resurrection.
Amen. And that is so true. You know, you mentioned suffering, Dr. Closson, and unfortunately, we are a society who is working very hard to minimize any sort of suffering in our culture or in our lives. And maybe that's why, you know, assisted suicide has become so compelling. But I wanted to ask you, you know, when we think about culture, you know, why do you think assisted suicide has become so popular around our nation, and why is there just kind of this skewed view of compassion and empathy when it comes to this topic?
That's a very significant question. And I think I can answer it succinctly by saying, you know, assisted suicide, it resonates deeply because our culture now is one that is shaped by what I think we could call radical personal autonomy. You know, most of the folks on the webinar are from the great state of Pennsylvania, the Commonwealth of Pennsylvania, Grove City College. Carl Truman, professor there, he actually wrote a book called The Triumph of the Modern Self. And he shows that over the last 100 years, kind of within the intellectual world, the intellectual strands, personal autonomy has become really the number one thing. And it makes sense, Kurt. We want control from the beginning of our life to the end, and at every point in between, we want control. We're told from really young ages that really the highest good is self-determination. This is reinforced in ways that might not even seem pernicious. I mean, you think of Disney movies telling, to follow your heart. This is the chief end, to follow your heart, be true to yourself. And so again, we are constantly bombarded with this message that we should control and dictate every aspect of our life. And if that's the message that the culture's pushing, we shouldn't be surprised when that same logic is being extended to how and when we die. Because when autonomy or self-determination, when it becomes ultimate, any sort of dependence, especially on others, well, that's kind of seen as undignified rather than just a normal part of what it means to be an embodied human being. I think there's more that we could say there. One thing I wanted to mention as you were talking about this, though, is I think there's also a profound fear of vulnerability that we experience. I think many people become very fearful of being a burden on their families, whether that's emotionally, physically, financially. And assisted suicide is often framed as a way to spare loved ones. But again, that logic, if you really think about it, is subtly communicating that some lives are no longer worth the cost of care. Right before we came on, Kurt, I pulled up a New York Times article that was published right at the end of last year. And I want to I'm going to pull this up real quick. This is from a state where this is legal. The New York Times article, the reporter interviewed a woman who desires to end her life, and it interviewed her sister and the mother who are ultimately on board. And listen to the way they frame it. Initially, her sister was aghast. Her sister was furious. They quote her saying, "I really saw it as giving up." But then the reporter says, but her view shifted after she thought about it for a few weeks. It's not if Claire dies, but how. Is it going to be compassionate or is it going to be violent? And the reporter went on to say her parents said they didn't want it to happen, but they reluctantly said they would support it because no mother wants to see incredible suffering, is how the reporter framed it here and how the mother was quoted. And so I think this is part of our culture. It's part of the milieu that we're swimming. This is how proponents are always going to frame it. We need to be ready for that, and we need to know how to respond.
That's excellent. I'm glad you read that, and I think we see this across culture, right? Where words have been hijacked, within culture to support, I would say, evil things, right? So they call something compassionate or understanding and things like that, and it tells you a lot about how our culture views human life, not only from the womb, but certainly here at the end of life. And oftentimes this topic gets left out when we talk about, the pro-life ethic, right? And we have to start including this in the pro-life ethic as we talk about the value of human life from beginning to the end of natural death. As we don't have a lot of time here because we want to get to questions, Dr. Closson, but one of the things you don't often hear about this topic within churches. Dr. Nolt and Dr. Marine earlier mentioned that this can be a challenging topic for some people to discuss and talk about. But I don't know the last time that I heard a message within the church community on assisted suicide. How can the church do a better job at giving a biblical ethic, a biblical worldview when it comes to assisted suicide?
Yeah, I think the church begins by recognizing this challenge honestly. Just a couple of months ago, Family Research Council, we actually partnered with George Barna, Dr. George Barna, well-known researcher, and we did a specific survey with regular churchgoers, and that's important because a lot of polls and surveys, whether it's Gallup or Pew, it's folks who maybe they'll ask you a bunch of questions, ask you at the end of it if you identify as Christian. Even if you haven't been to church in a long time, you're still marked down as a Christian. Our survey was regular churchgoers. And one of the series of questions we asked her is we asked them, do you desire additional worldview training on a whole list of issues, abortion, human sexuality, divorce, religious freedom? And we added the question, do you desire additional worldview training on euthanasia and physician-assisted suicide? And I was kind of surprised, but I guess not really, to find that this issue ranked lowest among worldview topics that people told us they wanted more teaching on. It was 54% was the number that expressed interest from their church providing more teaching. A full 26%, so a whole quarter, told us that they were not interested at all in actually hearing anything from their church on this issue. I think that suggests a couple of things. That suggests that maybe.
Yeah, I was going to say, well, what does that tell you?
I think it suggests that maybe some Christians view this as a distant issue. Some view this as an uncomfortable issue. Some maybe see this as not a pressing issue. But I think we just need to realize, and if there's any ministers, pastors, those with teaching and preaching responsibilities as part of this webinar, you need to realize this is not an abstract issue. This is a deeply personal and pastoral issue. I don't know if you saw it. At the end of last year, Illinois passed physician-assisted suicide. Any day now, New York is going to pass it as well. So we're going to have the fourth and sixth largest states pass a form of this in the span of a month. I think that'll bring the total up to about 13 states. So Christians and those in pastoral ministry, you are going to face these questions in hospital rooms, in counseling sessions. So yes, you're going to have this. This is a big conversation in the state legislature. But if you're a pastor, you can't hide from this question. You need to prepare people for this reality. And again, right before we came on, Kurt, I just did a quick Google search of the population of all the states that have this. It's about 100 million people now that live in a jurisdiction where assisted suicide is legal. That's about a third of the population. And so again, I guess just to sum this up, I think this means that teaching an ethic of life, we need to teach from conception to natural death and offer kind of these compelling alternatives to taking this way, as the previous two panelists shared about. Churches need to support. We need to talk about hospice care, and we need to support caregivers. We need to combat isolation. We need to walk faithfully with those who are enduring prolonged seasons of suffering. And I guess the final thing I'll say is I think the church, we really do need to recover a robust theology of death. One that acknowledges grief, but one that is anchored in resurrection hope. And I think when we model this patience, this presence, this sacrificial love, this will expose some of the false promises that those on the other side of this issue are offering. So I think that's the beginning of kind of how we as Christian leaders should be thinking about it.
That's so good, Dr. Closson. And I wanted to jump into our Q&A because we have a lot of great questions here. And I'm looking at the time here, and we might go past the 8 o'clock hour to address some of these. But just a great interaction from the audience here. And people who are viewing this, many are saying how important this conversation is. And I want to start, especially with the medical doctors here. Someone asked the question, can the MAM sanction or otherwise hinder the continuation of prescribing physicians' license to practice medicine when it comes to prescribing assisted a medicine for assisted suicide? I don't know who wants to take that one.
Well, most of the bills that I've seen, certainly the one that's been proposed in Maryland, specifically states that a medical board cannot sanction a physician who practices in accord with the bill, so long as they follow the steps and rules that are made in the bill, if I understand the question correctly.
Excellent. And this question
And
here
in
is,
fact, I would say that even beyond that, most of the bills that I've seen have immunity for the physicians,
wow.
so that you cannot even question, a family member who is surprised by what might have happened, has no way or no legal recourse to even find out exactly what happened and if the process was followed according to the law.
That's awful. But thank you for sharing that. Tom, a couple questions about here in PA. What is the likelihood of a physician-assisted suicide bill being coming out of committee and even coming on to the House or Senate floor, in this session?
Sure. Well, the shorter answer is it's hard to predict. It's hard to know for sure. We're monitoring it closely as we are with some other bills that affect sanctity of human life. But it is more likely to come from, with the current makeup, it's more likely to move in the state house than it is the state senate. And it would be committee considering it and voting first. And so we're watching that, and folks can watch it and sign up for alerts through pafamily.org. I'd like to say I know, but I don't, and we're just watching it. But I will say the pressure is increasing because neighboring states are legalizing it.
And Tom, correct me if I'm wrong. I mean, this bill has popped up a number of times throughout the last 10 years in Pennsylvania.
Yes, and each time has not gotten any traction, but things can change very quickly,
Sure.
especially with national advocates. If they turn their focus to Pennsylvania, there'll be a lot of messaging and those kinds of things that we need to understand what's behind, and that's part of the purpose for the webinar.
I'm going to throw the next question to Dr. Holt. Aside from misdirected compassion, what other than encouragement from a pharmaceutical industry would motivate a physician to prescribe the death of his or her patient, certainly in the Hippocratic, vow, hereby diminishing his or her financial income?
Well, thank you for the question. What I'll say is I get the sense that at least those that are advocates for this are primarily in their framework and their value systems coming from a compassionate standpoint. They believe that this is what compassion looks like. But I would like to address that, and I think Dr. Maureen will cover this as well, but the financial aspect of things in the big picture about a driver for expansion. So, Dr. Maureen, you want to mention about that?
Sure. Well, it's just kind of interesting that the founder of the modern euthanasia movement, Derek Humphrey, who wrote the infamous book Final Exit, wrote in a later book that economics, not the quest for broad individual liberties or individual autonomy, will drive assisted suicide to the plateau of accessible practice. It's really a striking quote where even the person most involved in bringing euthanasia into the modern world admits that it's economics that drives a lot of the thinking behind it. And obviously, this creates so many potential conflict of interest for insurance companies, hospitals, and even physicians. There was in Canada a article that was written by health economists who calculated the amount of millions of dollars of savings that the Canadian health system would see once they passed their euthanasia law, bringing the question out into the open.
And that just shows um, how little they value life. The dollar trumps, the value of life in that regard. Here's an interesting question I want to pose to you is, someone wrote in here, actually a hospice nurse. Thank you for serving, by the way, Ellen. And she has the question. Typically, life insurance companies life insurance is denied to those who commit suicide. How is that being addressed with assisted suicide?
That is a good question. And the proponents have thought of this, and they write into all of the laws that very specifically that this would not be regarded as suicide for any legal purpose, and for certainly for life insurance purposes. So they specifically have thought of that, anticipated that. And then in addition, you have the falsification of the death certificate. So it's required to say that it was due to a natural cause, the underlying illness, or rather than assisted suicide.
We've also kind of touched on this, but some of these decisions seem to be really driven by finances and money. And David, you mentioned this as well. You can have an elderly person who says, "I don't want to put my family through this. I don't want them to have to pay lots of money for my care. So, just put me out of my misery." And those are really hard conversations, certainly to have. That shows what might be going on in that person's heart and their experience. But David, you touched on this, and I want to hear from the doctors too. How does a family address some of those things?
I think specifically a Christian family hopefully is embedded in a church community. And you need to make sure that if you have an older family member or someone who has a terminal diagnosis, that the ethic in that family, the ethic in that church community is never one that is even in a subtle way going to imply that anyone would be better off if that particular loved one was no longer with us. I know my church in Washington, D.C., we have several seasoned saints who have been at the church members for 60, 65 years. All of us go out of our way to honor those people whenever we see them. Even with the massive snowstorm we've had, I've seen on our church email list, making sure people are running to their houses to shovel their driveways. And I think part of it is making sure we are living in a Christian community that actually practices the ethic of Jesus. Again, no one in our families or our churches should ever be able to consider that thought that they'd be better off if I weren't here because they know that we love them. That's easier said than done, but that needs to be the baseline of what Christian love and accountability looks like in community.
Dr. Marine, any thoughts?
Yeah, I wholeheartedly agree. And while the economics considerations have not come into open discussion in the United States, it has in the discussion that's happening in Parliament right now in Britain, where they're debating their own form of this law. One thought experiment I do is I imagine if palliative and hospice care were inexpensive and assisted suicide were expensive, I think there would be a lot less support for it in our legislature. So I think that kind of speaks to the quiet, saying the quiet part out loud that sometimes we don't want to talk about.
Yeah, thank you. I'll end with this question, and I'm sure you all might want to address this. And I talked earlier about within the pro-life ethic, we must be including assisted suicide and euthanasia within the conversation. And this person wrote, and maybe Dr. Holt, you can start with this question. This person said, "So it sounds like this bill, like assisted suicide, would be another form of the abortion pill for other people." Any thoughts on that?
I think there's a sense where it really moves the power of taking life to the individual, and in a sense, sort of makes everyone else not accountable for that. And it leaves it to the self-administration of the person and their decision. So I think there's an attractiveness there from those who would support it. So I can see the parallels. And for that reason, I think there's even more concern because the accountability is still there. There's still a community support for that decision. So I do want to emphasize that point. I do see parallels.
Any others? You make additional comments or talk about that particular question?
I think I would just add, Kurt, we shouldn't be surprised. Again, I'm speaking as a Christian ethicist. When the culture of death, uh, it's going to go after both sides. It's going to go after the beginning of life and the end of life. I wrote a book last year on the abortion issue. Write a lot in there about the chemical abortion drug. Of course, we know 63% of abortions now take place through self-administered mifepristone pills. And so again, I think we shouldn't be surprised when the culture of death, it goes after the most vulnerable. Again, and that's why if we're going to be consistent, the other side often charges us not being consistent. We need to be those who are advocating for life from the moment of conception until the point of natural death. And we not just say that, but we really mean that in our advocacy and our work. And so I think, again, we shouldn't be surprised, but it should cause us to redouble our efforts, though, to be consistent in our ethic.
Dr. Marine, last comments? We'll give you the last word. In my house, I always want the last word, so we'll let you go.
Well, thank you for being here. And, I appreciate, I've learned so much from my colleagues and from the people that I've met on this webinar. I've been involved with trying to stop these laws for 9 years. There are so many reasons to oppose. So whatever your motivation, whatever brings you to this, I hope that we've given you some ideas, some thoughts, some ways that you can speak to your friends, your neighbors, your colleagues, and your legislators about this. Again, I think the bottom line is that this is really terrible public policy. So no matter what framework you come to approaching this, this just is not the way.
Well, thank you all for joining, and really appreciate everyone taking time out of their evening to join this webinar. And I thank you to our panelists, Dr. Closson, Dr. Marine, and Dr. Holt, and certainly Vice President of Policy, Tom Shaheen, the whole crew here. We thank you for joining us, and we hope everyone has a blessed evening tonight. Take care, everyone. God bless.